Good morning, Milwaukee, and welcome to Your Health and You on WNOV 860, The Voice. Deb Nevels is away today, and I'm Marquela Ellison, stepping in as guest host. During Black History Month, we are exploring genetics, truth, and trust. Before we get into science, we begin where we always begin with lived experiences. I want to introduce the health griot, Mr. Willie D. Ellis. And we have some questions and some things for you. But do you want to introduce yourself first?
Yes, my name is Willie D. Ellis. I'm a prostate cancer survivor, and I'm also an instructor at WRTP Big Step, where I work with young people, getting them into apprenticeship trades.
Awesome. Thank you so much for being here this morning. And I have a bit of background. I'm a graphic designer, so I actually did the logo for Health Griot. So nice to see it out and in action, which is cool.
Well, thank you. Ambrose will be proud of me.
Yeah. Let's get into a couple questions. What led you to explore your ancestry and family health history?
Well, one of the things was in my family, there was a lots of cancer and so forth. My great uncle, Uncle Andrew, which was Andrew Jackson Herman, which was my mentor as I grew up as a young man, and he passed away from bone cancer. And also, along with that, is my mother had breast cancer, and several uncles and other relatives basically had colon and prostate cancer.
So a long history of it and being mindful of it. Did you come from a background where other family members were mindful of the history, the health history as well?
Yes, we were mindful of it, and I guess in having physicians and so forth, and the doctors going getting our regular checkups and so forth, we had a tendency uh, to make sure that we got our yearly checkups, and the family basically talked about cancer. But lots of times, let me say, they would say that your uncle, your aunt died from cancer, but they never really told us what type it was and
Mm.
so forth. So as I grew older, I started doing some research, basically looking into family history and so forth.
Right. And what concerns did you have in hearing about your family history?
Well, I was concerned about myself, but even though I went yearly and had my checkups and so forth, back then they invaded your privacy basically with the finger, and they said that I didn't have an enlarged prostate and so forth. So that was the tests that I was getting. So at the age of 64, I went to my doctor, and she says, "Have you ever had the PSA blood test?" And I said, "No." She says, "Well, today we're going to make sure that we get that done." So it was my regular checkup. I went back to work, and about 3 hours later, she calls me and said that I needed to come back in. She says I could come in either that evening. I could make an appointment to come in because she needed to talk to me because my PSAs were high. And so, knowing basically treatments basically that they had it, I wasn't overly excited, but I did feel like, okay, this is something that I need to do. And so I called my wife and told my wife I had the appointment. So she went in with me. I guess she called my daughter. So my daughter basically said, "You know what, Dad? We all going with you." So my daughter and my wife basically went, uh, and we talked to the urologist and the oncologist, and we started prepping. So then they decided, well, we got to um, dig into this a little bit deeper. So I went and had a MRI and so forth.
Great. And I always like to chat more about that PSA or that exam. And as you said before, it was a different experience back then than what it is now. Dr. Izzard, do you mind introducing yourself and maybe telling us a couple updates about that
Yeah.
experience?
Good morning,
Good
friends.
morning.
Good morning, Milwaukee. Good morning, fam. I'm back again. And yeah, I'm happy to hear Mr. Ellis. He's one of my favorite griots.
Well,
Yeah,
thank you, sir.
yeah. Mr. Ellis has been doing this for a while. and there's something interesting thing about his story. I think is that I'm kind of curious. How? Oh, let me tell you. I've introduced myself. That's what you asked me to do. I'm Kevin Is, and I'm a family physician, president of the Cream City Medical Society, and longtime resident of Milwaukee, Wisconsin, born and raised here. But Mr. Ellis, you said you were 64, but when you were first diagnosed.
Yes, sir.
Yeah, and no one had brought it up before that about getting screened. Huh?
No one had
Wow.
brought it up. And like I said, I've always had. I felt I had great physicians and so forth.
Mm-hmm.
But I guess because I was healthy, my blood pressure was fine.
Mm-hmm.
When I would go in, I had no complaints. I had no symptoms or anything.
Mm-hmm.
So I equated that to is maybe why I was never basically told that I needed to take a PSA.
Yeah. So, are they talking about other cancer screenings like colonoscopy or anything like that?
Yes, I always have my colonoscopy done. Fact is, I just had one done 2 years ago,
Wow, that's
and
interesting.
everything was good. There was no
Yeah.
polyps and so forth.
Yeah.
So thank God.
So you talk about colon cancer, not about prostate cancer, because prostate cancer is the most common cancer in men. So I'm surprised that you got that far without getting screened, and I'm glad you did because, as you say, they found it out. You said they called you like right away after you got the test done.
Yes, my doctor called me right away.
Wow, I wonder how they got the results back so fast. So what did you mentioned that they called you and said I can see you in person or we can do
We can do a phone.
phone. Yeah. So I don't know how are you feeling at that time?
Well, actually, I guess maybe because of my upbringing and so forth, and my belief is I felt okay. It must not be that bad because I feel good.
Mm-hmm.
I'm still doing the same things that I've always done,
Mm-hmm.
and so my wife and I went. And to tell you the story, the only thing that really upset me about the whole issue, that really totally, by time I got home from work, my sister-in-law called me. Everybody was calling me, telling me this. My daughter's father-in-law called me, and I was really upset because it hadn't given me time to really digest the diagnosis that I just had.
Yeah.
So I felt a little bit ill toward the family at that particular moment.
You know what? I mean, a lot of times, it's the women that drive the healthcare.
Yeah.
Yes.
As far as making us go to get our visits, a lot of them are the ones that they might have the insurance, and they might be the ones that are setting up the appointments, and with the husband and the kids, and
Right.
So women are really thank God for women because we.
Yeah, I thank God for women, but sometimes I think give that person the opportunity to digest this life changing.
Yeah. Well, I mean, in the day of how these HIPAA rules about sharing of information, how did they find out? Did you take someone with you?
Yes, I took my wife and my daughter with me.
Okay, and
Yeah.
so we know where it came from, right?
As a woman, we're just so concerned. We like, no, just go now. Please just go now.
You will get a prayer chain going, right?
Yeah. Yeah.
And I guess because my daughter was a radiologist tech, so she was very familiar with everything, and now she's in doing research, and she's working from home as a radiologist. Research.
Yeah, and that's important too when you go in, because a lot of times you go in for that visit and you're going to hear the C word,
right?
And once you hear the C word, everything else just kind of blacks out, right. and you don't hear anything else you're talking about as far as what your treatment options are, what the next steps are, or how you got this. You just kind of focus on on that cancer diagnosis, and it helps to have somebody with you who could ask those questions, especially someone like who maybe have a medical background who could ask those questions for you.
Right, and there again, I guess like I said, in the family, my wife basically is a breast cancer survivor, so basically we had been through a lot of the orientations and so forth, and so I guess that helped prepare me also. And I knew that she's a 25-year cancer survivor, so breast cancer survivor. So I guess that gave me the confidence that this isn't something that it's going to change my life, but it's not going to. I'm not going to die from it. That was the way I felt the inner me.
That's powerful. Dr. Izzard, can you talk a bit about the difference between the DRE and the blood test that's available now?
Yeah. So when Mr. Ellis had his, and this is going back until just recently, the digital rectal exam, we call DRE, was part of the routine screen. And so you'd go in, and this is always an issue. So you'd ask guys, Jermaine can tell you, we ask guys, you're going for, do you want to be screened for prostate cancer? And the first thing you think of is that rectal exam, or what they call the violation.
Yeah,
Violation.
Yes.
And most of the guys will say, no, thank you, because they're, again, like you said, they're feeling healthy and they don't feel like they have any signs of cancer. So, they say no. Well, what we've known is that the vast majority of cancers are going to be picked up with just the PSA blood test, because that was, again, the screening part consists of two parts: the rectal exam and the blood test. A lot of times you're getting blood drawn anyway, so they're checking your cholesterol or your other labs, and so it's easy to add the PSA blood test onto what you're doing, and so it makes it a lot easier for guys to do it that way. So we've known this for a while, that that the digital rectal exam was a hindrance for a lot of guys, and in fact probably more of a hindrance than a help, because there are very few cancers that you're going to pick up just on the rectal exam and not be supported by the PSA. So where you would have a abnormal rectal exam and a normal PSA blood test. So in the past year now, the major organizations have said we should just stop doing routine rectal exams, because it's more of a hindrance than a help.
Mm-hmm.
Now, I'm going to warn you that if you do have cancer, if you do have an elevated PSA, you're likely going to get a rectal exam at that point, from the urologist or from your primary doctor. But as far as routine screening, yeah, we're not doing the digital rectal exam. So good news for you guys: get out there and get screened if that's what's been holding you back.
Yeah, and at that time, just dumbing the language down, it's like a level 2 concern. So you don't hesitate to get checked, because it's not a DRE. But if they happen to find more, then there's a chance they want to investigate further. But yeah, every time we talk about it, always trying to make sure we lay out the newest information, because
Yes, right.
it is a funny joke, but just making sure people have the facts, so we don't stop them from attending. But Mr. Ellis, thank you so much for sharing. I just had a couple other questions for you. And you kind of answered it already, but what did you learn that changed how you feel about your health just from this experience?
Well, from that experience, one of the things that I learned was through the medical college and so forth, changing my eating habits, exercising. And I have to give my coach, Leonard Wilson, a great respect as far as encouraging me. It's when I first started in Men Moving Forward, I could only do 5 push-ups, and I thought this is this last year, 2025. We did 13 sets of 55, which
Wow.
means 715. Remember the great home run hitter Hank Aaron?
Yeah.
We met that.
Oh,
Wow.
Yes, we met that. And the other thing is, like I said, is now I'm a full-fledged vegan. I don't eat meat.
Okay.
I don't eat chicken. I don't eat fish. I just eat vegetables and plant-based food. I probably drink about 7 bottles of water a day, so that keeps my body flushed and so forth. So I would say to anybody out there, is one of the most important things is getting screened. Also, talk to your family, look into your family history, and so forth. And one of the things that I've learned through this is because, and I didn't know that it had anything to do with it, is breast cancer and prostate cancer has some of the same identical traits that's involved.
Yeah.
wonderful. And you made so many life changes. I almost wonder what that experience is like, to go from eating meat to being vegan and, dropping other things. I don't know if you drink or not, but,
No.
drinking more water. What helped you make some of those decisions to be like, man, okay, I'm going to cut this. I'm going to cut that. I'm going to be consistent.
Well, I guess it was the inner me, and I have my sister basically has been a vegan for probably 25 years. My niece and her family lives down in Arkansas. They are vegans. They've been vegans probably for 10, 12 years, and the kids basically were brought up as vegans and so forth. Hopefully they won't stray away from it. But what I found is I have more energy. I just it's a step. let me tell you, people out there, radio people, it isn't something easy. You got to start by steps. So basically, I stopped eating um, pork and beef. Those were my two biggest things. And then I stayed on chicken and shrimp, crab legs, stuff like that. And just one day I decided that, you know what? Uh, I'm going to cut chicken out. So then I was only doing seafood.
Hmm.
So then I decided that I was going to cut out all of the other seafoods and so forth. But I want to tell you, the biggest thing and the hardest thing is was my little pet peeve was ice cream. Yes,
Mm.
dairy was the hardest thing basically to get rid of because at night about 9 o'clock before I go to bed, I had to have me a scoop of ice cream and I'd sprinkle coconut over it.
Hmm.
That was and so the life change basically has made a big difference, and you got to do it in baby steps. You're not able basically to do it just cold turkey.
Hmm.
It's just like smoking. You got to basically uh, cut back, and then eventually, and you see that you feel better, and you also look at, okay, I can do this,
Yeah.
and that's one of Coach's favorite words is I can do this.
Hey, Quay, you mind if I ask?
Please.
Now you said your wife had breast cancer. She was a breast
Yes.
cancer survivor. So
Yes.
she had been so many years before
Right.
you got your diagnosis. What was her journey like compared to yours? They're very different cancers, I know.
Right,
But
it's a very different
yeah.
cancer, and her journey basically was I can say she had her biopsies and so forth. She had surgery,
Mm-hmm.
and so she was able basically at no time basically was she restricted from not working and so forth.
Mm-hmm.
So she kind of changed some of her eating habits and so forth. But she's not a vegan yet. But I can tell you when I prepare my plant-based foods and so forth,
Mm-hmm.
is she does. She has changed her eating habits. We go to Health as well on Mondays and Wednesdays for exercising class, so she
Mm-hmm.
enjoys that. So she's
Yeah.
changed lots of her habits, and her
Yeah.
journey basically is having her mammograms every year, and now she gets them done every 6 months.
Yeah. So I imagine, that by her having had that diagnosis and surviving and doing thriving, that because of that, you probably weren't as afraid when you heard about prostate cancer because you've seen that people with cancer can go on and live full lives.
Right,
Yeah.
and I must say also is my mother basically had breast cancer. Also, she had had one breast removed,
Mm-hmm.
and she lived 10 years after that.
Mm-hmm.
So it's like you said, I think that really helped by being exposed to it and knowing. And that's why I said,
Mm-hmm.
when I was diagnosed, it wasn't a death notice.
Mm-hmm.
That was my belief from the beginning.
Yeah.
Very powerful, and I'm taking so much from it. Just hearing your family history and the family support and background, um, all accumulating to who you are now, and being able to be a survivor and chat with us today. Just to wrap it up, what would you tell someone who is feeling hesitant about getting tested or just being mindful and keeping their health?
Well, basically, what I would say to you is don't be afraid. Get your screening done. Talk to your family, and just make sure you go out and get your checkups done. You get a yearly checkup. You also basically need to talk to your family members. Make sure that if there's cancer in your family, is that means that you should go and get a checkup right away. Thank you.
Thank you. All right, we're going to take a short break. Thank you. right, welcome back to You and Your Health. We have a call we're going to take. Good
Good morning.
morning.
Yes, good morning. Thank you, ma'am. Good morning. Uh, Forgive me, I may have missed your name there along the introduction there, but
We call it Quay.
Yeah.
oh, okay. Well, well, thank you. Good morning and best wishes for the new year to all of you.
Thank you.
Well, thank you.
My friend Tito Izzard there, and your brother Kevin as well.
Hmm.
Yep, yep, and the other young man as well. Good morning, Jermaine. Mr. Debo and Milwaukee, Tyrone W. speaking again. A couple different things. I mean, I'll tell you because I talked to Santita some a couple years ago on her show, and God bless her and prayer to the Jackson family as well. But I had called Santita. Oh man, and she was I guess whatever the topic was, and I said, "Oh boy, you're getting ready to get one of these doctors straight up clocked because it's it's such a sensitive area down there, you know." And I mean, to be poking and probing around front or back, I mean, man, even the old girl got to be careful on how she handling that stuff down there.
Yeah.
You about to get one of these doctors straight up knocked out. Not you all, but just in general.
Yeah.
But no. On the serious side, though, all jokes aside, if any at all, I know my legs are bad there. From either the Roundup or this piss water that came up. They say when it rains hard, the tunnel MMSD. It goes out into the lake or it comes back up through your home.
Yeah, the deep tunnel.
The deep
Right,
tunnel
right,
project.
right. The floor drain there, and that's what happened a few years back. It's been about 12 years now, but I had to bail that there, and I had my dogs back then. Since then, all my dogs have died. But they don't tell me. It's called lymphoma, whatever. Lymphedema, and it's my both of my legs haven't been the same since. But they won't say, "Oh, it's not from the Roundup." Well, how do you know if you haven't tested for the Roundup?
Mm.
Or
Yeah.
but they didn't say it was from the piss water. It's from one of the two,
Mm.
because behind those two, and I don't use Roundup anymore, but my legs have never been the same.
Mm-hmm.
But now back to, but I was going to see them. I went over to 27th and Layton at the little center they have over there, and well, I guess mammogram ultrasound. I got an ultrasound,
Mm-hmm.
and I determined that there was a blood clot in my right leg.
Oh.
So they gave me a blood thinner,
Yeah.
which made my heart feel heavier. So I stopped taking that. I said, well, no, I'm going to take myself off this because this is making my heart feel different from what it normally does.
Mm-hmm.
So I took myself off of that, but I still do my regular walking and stuff,
Mm-hmm.
and they didn't give me anything for pain. So I go to Walgreens and I'm just resulting and settling for Bufferin extra strength or Excedrin extra strength
Mm-hmm.
out of my own pocket.
Yeah. I'm glad you got it checked out. A lot of times we self-diagnose, and you probably, I don't know if you were thinking that it might be a blood clot, but that could be a serious thing.
Right.
These clots is that the clot in the leg isn't
Mm-hmm.
necessarily the problem. Is if a piece breaks off and it
Absolutely.
goes up to your heart and then out to your
Oh,
lung,
yeah.
what they call a pulmonary embolism. You can die suddenly from that. So
Yeah.
I'm glad that you got that checked out.
Yes, sir. But then, and I'll close with this because I don't want to suck all the air out the show. But so I know they've got this big machine. I don't know the name of it there, but mammogram ultrasound is what I got. I got ultrasound.
Mm-hmm.
So I guess you can kind of go back and forth between what the similarities or differences between ultrasound and mammogram. But they got this big machine that kind of does like X-rays. Now, instead of them doing all this, tickling, because it's a sensitive area, we all know that down there. So doesn't this big body machine kind of make it a little bit easier for you to like take the pictures and stuff that you need to to kind of get to get at that down there? Because I mean, if a woman's giving birth and you've got her in stirrups, and her legs are up, I mean, I don't know if the man's going to do that, but you can at least get some X-rays of what's going on down there with him.
Yeah.
And I'll listen to you over the air. I wanted the callers to get in, but thank you. Nice talking with you.
Yeah, you too. There is a new technology for screening for breast cancer with ultrasound, and so it's a new cutting edge thing. Because it's new, insurance doesn't cover it primarily. So if you do want that done, it's something that for women, discuss this with your doctor if you're interested in that. I guess we're still trying to find out, how sensitive it is compared to the mammogram, which has been the old standard. One advantage of doing the ultrasound is that ultrasounds don't have any radiation, so if you're particularly concerned about radiation exposure, but ultrasound is really just sound waves. They bounce the sound waves off of whatever organ they're looking at. So in this case, your breast with your leg, they would look at bouncing sound waves off your veins in your leg, and you can tell the ultrasound is sensitive enough to see flow, so they can determine if there's flow going through and look at those major veins in your leg. And what they saw was that there was no flow going through that vein, and that's how they determined that there was a blood clot there. And then usually after that, we put you in a blood thinner because, just naturally, your body is going to break down those blood clots. It just takes a long time for it to happen, and you're concerned during that time where it's breaking down that a piece of that clot can go off and, like I said, go to your lung, and you can die suddenly. So usually we put you on a we say blood thinner, put that in quotations, but really it's not a blood thinner. It's an antiplatelet or anti-clotting medication that helps to break the clot down, and again, hopefully prevent you from getting that blood clot moving elsewhere. That's what we call a embolus when it moves. But thank you for the call.
Thank you. And we'll get into our next segment. So again, guest host today for Ms. Deborah Nevels, Marquela Ellison. And now we're going to transition to talking about what genetic counseling is. We have another guest here, Miss Jenny Gertz. How you doing this morning?
I'm well. Good morning.
Good morning. You mind introducing yourself and telling us more about what you do and genetic counseling in general?
Absolutely. So, yes, my name is Jenny. Also born and raised in Milwaukee.
All right.
Real town.
So I practice over at the Medical College of Wisconsin, and I'm a genetic counselor. So that means that I got some specialized training in genetics to help understand how things are inherited in a family. And so that's what a genetic counselor does, is we talk with families. In this case, we're talking about cancer, but we also see patients for, heart disease, or if they have a baby, there's a concern about that, or a child born with a birth defect. So we meet with families and we talk about how something might be inherited. Sometimes we're able to offer genetic testing to help uncover what the risks might be for family members. And then we just talk patients through that decision-making process to see, is this genetic testing right for them? What are the risks? What are the benefits? What are the limitations?
Okay.
It's just a test. It's not a crystal ball. That's what I tell people.
All right.
So yeah, that's what I do. I
Okay.
love it.
And what does that process look like for genetic testing? I've done it before. My mom is a breast cancer survivor, so it was recommended that I go and get some testing done, and I learned some things, and it made me more mindful of the possibility. But what does that journey look like if somebody wanted to come in and utilize
Pursue
these
the
services?
testing.
Yeah.
Yeah. So the first part is the office visit. So the genetic counseling, it's just a conversation. And I think that's really, like, if we can get people to the door to have the conversation, it doesn't mean they have to have testing, right? And I'm sure hopefully that was your experience as well. Hopefully you didn't feel any pressure that you had to do it. It's about getting the information so you can make an informed choice, that's right for you. But the actual process of genetic testing is simple. It's just a blood draw, right? Or you can actually do saliva now. We have the technology where you just spit in a tube. So it's not painful, but there's something sacred about DNA. It's a little different than going to get a PSA or just a blood test, a CBC. There's something special about DNA. And that's why we give it a little extra attention, a little extra thought. We have to be mindful, because when we do a DNA test, it's not just about us. It's about our family, right? So like when you had your PSA, that was just about you. That wasn't about your family, right?
Yes.
But a genetic blood test is about your family. So that's why we want to have a conversation.
Wonderful. And how is that different than like an ancestry testing kit?
Yeah. So ancestry tests are what we call direct to consumer tests, where you can go on a website, you put in your credit card information, and then they ship you that saliva kit and you spit in the tube. So the DNA collection's the same, but that's probably where the similarities end. So some of these tests like 23andMe, they might say they give health information, but they're really not meant to have you make medical decisions. So I call them, recreational. sorts of tests. So it might be fun, a good hobby, especially if you're into genealogy. You can trace your ancestors, go way back, see who you might be related to, which again, buyer beware, because there might be some surprises there.
Yes,
so
that's
just
true.
be careful, know what you're
Mhm.
getting into with those ancestry tests. But the genetic test that happens in, your doctor's office or your provider's office. It's ordered by a trained professional. It's much more comprehensive. We're looking at all of the genes, in the case for cancer, all the genes that may cause cancer. So it's much more comprehensive, and it's meant to guide medical decision making. Those online direct-to-consumer tests, you shouldn't make medical decisions off of those.
Right. You said something and that I was going to ask about. So how do people actually get to you, get to the point where they're having genetic counseling? Are they self-referring? Is their provider referring them to you? And let's answer that question, and then we can talk about asking for it.
Yeah. How did they get to my doorstep? Well,
Yeah.
so there's two ways. The traditional way would be with referral, so that the doctor recognizes, oh, you say you got a family history of breast cancer, prostate cancer. Okay, well, why don't you go see genetics? But the problem is that doesn't always happen consistently.
Okay.
And sometimes our health providers aren't aware of, the latest connections with genetics, like prostate cancer being linked to breast cancer. That's kind of newer. So if somebody was trained years ago and they didn't know, they may not refer. So we also encourage self-referrals. So we'll tell patients, if you're concerned about your family history, be a self-advocate. We'll take a self-referral. Come on in. We'll have a conversation. We'll work up that family history. We'll help you get the family information together, and we'll look at your insurance and see, do you meet criteria for genetic testing based on what we see in the family history? Because most insurance companies actually cover the genetic testing when you meet their criteria. So if someone comes in and says, well, I don't have any family history of cancer, it was just my neighbor that had the cancer, well, then they're not going to cover that. Right. So but like your history where you were talking about, there's multiple people in the family with cancer, different types of cancers that could be genetically linked. Or even if you're the only one in your family, but you were young, like breast cancer or colon cancer under 50, that we consider young. Or there's some cancers like male breast cancer. For example, if a man gets breast cancer, it doesn't matter the age or if he's the only one in his family, we would offer that genetic testing because that's so uncommon. The other cancers that we see, regardless of age or family history, is ovarian cancer, so in women, and pancreatic cancer. So those two cancers, even if you don't have a family history, most insurance companies cover that genetic testing. So I appreciate your question. Both the provider can refer, but also if people are hearing the story and saying, this is something I want to know about, you can self-refer.
If there's anything that the audience out there is listening to, our listening audience could take from this is you got to be an advocate for your care, and so if you got a question, if you got a concern, discuss it with your provider, and feel free to discuss those kind of things, because a lot of times it's good to have that conversation with your provider because they need to know your history also, and so if you find out, oh yeah, my brother now was diagnosed with prostate cancer, and you never tell your provider, well, that might make a difference that, he might suggest that you, or he or she might just suggest you get screened because at an earlier age than you normally would have. And Mr. Ellis is smarter than the average bear, but most people don't know that connection between the BRCA gene and that increase your risk for prostate cancer. So a lot of times, even as providers, we're not making a connection between, I have this woman here had prostate cancer, maybe her brother should be getting screened, woman had breast cancer, and maybe her brother should be getting screened for prostate cancer earlier.
Right.
All right, we're going to just take a quick break, and then we'll be back to continue this.
Call.
Phone call. Apologies. We have somebody dialing in. Good morning.
Good morning. Thank you for taking my call. For the genetic testing counseling, could I go and find out how long I'll live?
She asked for genetic testing. Would it help her figure out how long she will live?
Oh, longevity. No, unfortunately, it's not a crystal ball.
I knew you were going to say that.
It's
not a crystal ball.
It's not. Yeah, and I mean,
so does it pick up? Does it pick up if there's a potential for a disease? Like my grandmother's still living; she's 88.
Right.
And
it's the potential. Yeah.
potential. So then they could possibly tell me I'll live till 95 then, right? Based on her being 88 now.
Well, just like when someone's diagnosed with cancer, we don't tell them how long they're going to live, right? Like
that is correct.
there's no expiration date stamped on the bottom of your foot. So
And I get that. I was just trying to explore other ways or benefits that this test will bring for getting it. You know, it's kind of obvious if my mom had breast cancer, I may have it. So I'm just trying to understand a little bit more of the benefits of scheduling an appointment with you.
Yeah, so let's
thank you. Have a great weekend.
Yeah, thank you. Let's dive into that. So although we can't tell you how long you're going to live, we can do the genetic testing that might say, okay, well, yes, there was breast cancer in the family, but based on what we're seeing and the genetic testing, it's not something that's inherited. So just because there's one person with breast cancer in the family doesn't mean it's automatically inherited, right? There can be other reasons that happens, and in fact, most time it's not inherited. So we can use the genetic testing to rule out things. Or if we have a positive genetic test and we find what we call a genetic mutation, there's a change in the DNA there, then we can say, okay, here's what we found. And now, we know your mom had breast cancer. Yes, that's relevant. But now, instead of just getting a mammogram every year, you're also going to get a breast MRI, a more sensitive test to find breast cancer early. Or we know that this is genetically linked with ovarian cancer. So let's have a conversation about what's going on with your ovaries. Are you done using your ovaries? Are you done having babies? Are you closer to menopause? Could we preventatively remove those ovaries and actually prevent the cancer from happening in the first place? Because ovarian is one of those where we don't have a good screening for it. So, that it's really refining. So I appreciate that caller's question of, I know my mom's got breast cancer. Of course, I'm going to be at higher risk, but it's refining what that risk is and what we can do about it. Because some people, their risk for breast cancer is so high, they actually choose to have their breast tissue removed before they get breast cancer, something we call preventative mastectomy. So it just helps refine that risk and then gives us an idea of how we can best either prevent the cancer, that's the ultimate goal, or find it early.
And it feels like prevention is key. So you don't get longevity out of it, but you get to be kind of mindful of this is what's going on, and these are the steps I need to take to keep myself healthy. So I know when I got the genetic testing, I only think about like my close family. I don't think about like beyond that when it comes to health history. So it made me more mindful, that I need to, think about the bigger history of cancer in my family, and that there is a story there. But before my mom was diagnosed, I just thought, oh, this just happened to her, and we're gonna make sure she gets better and then go on about life, and never thought, how does this affect me? So
So Jenny, what happened? I'm sorry.
I was going to say is thank you for bringing that up. Is I have a very close family member basically that was diagnosed with cervical cancer, and what happened was then she also has bone cancer. So they recommended that her sister and her mother and everybody should have genetic testing and so forth. So that answered it within me why basically she was recommended to have that done.
And I just want to clarify. So she probably had ovarian cancer.
Right.
We got a lot of parts down there. And so, so cervical cancer, that's the one that's caused by a virus that happens in young women, but that's not inherited, but the ovarian.
Yeah, ovarian.
So you just got to get your lady parts right.
But you bring up a good point though, that some cancers are genetic and some cancers are not.
Right.
And that's a very key thing,
So cervical cancer is caused by a virus. So that's why now we have a vaccine for that. They do the pap smear in young women.
Right.
And that is, again, something where we don't have a genetic test for because it's not inherited. So thank you, doctor, for pointing that out.
Yeah. Mr. Ellison mentioned something earlier too about, a lot of times, even if you do know your family history, grandma died of cancer and they have no idea what kind of cancer. So how many often do people come to you and they're saying, Aunt Berta died with cancer and mama died of cancer, but they don't know what kind, and then how do you make connections with that?
Right. Or like Markela was saying, like you just think about your immediate family, but we talk about 3 generations. Okay. So when we talk about 3 generations, we're talking about your immediate family, so your children, your siblings, your parents,
Mhm.
that's your first generation. Then we're talking about going out to your second generation, your aunties, your uncles, your nieces, your nephews, and your grandparents. Going third generation is kind of hard because now you talk about great uncle, you talk about your great, like what happened back then. Did they even know what cancer was back then?
Right.
Nobody talked about it.
Right.
They just went in the hospital. They didn't come out like that. People say that. Well, I don't know. But
Mhm.
your cousins are your third degree relatives as well.
Mhm.
And those people are usually closer to your age. So you may have more connection to them. So I'm glad you asked this question because ideally we want to get that many people written down on the family chart.
Mm.
And to get that information organized, maybe in your family you have like a genealogist or somebody, maybe not a genealogist, but somebody that knows everybody's business.
Right.
So everybody's got that auntie, right?
That nosy aunt you got,
Your auntie, right? So we just got to start organizing that information. It could just be a piece of paper or a spreadsheet, where you start writing down, okay, who was it? Where did the cancer start? So you talked about your great uncle with bone cancer. Back then, they maybe didn't even know where it started, right?
Mhm.
Right.
And a lot of times people say bone cancer, but it may be that it started in his colon and spread to his bone.
Right.
It started in his prostate and
Mhm.
spread to the bone. I mean, back then, men probably didn't even know they had a prostate, right? They
Right.
didn't talk about that.
Yes.
So I think, it's hard to get detailed information going back, but maybe your cousins have more detailed information,
Mhm.
right? So
okay.
where did the cancer start? Right? Because if it spread, that's important, but where did it start? And then the age of diagnosis.
Mhm.
So those two things, where did the cancer start and how old were they when it first was diagnosed? Because maybe like your wife, let's say she lives to 100 years old. And so that's wonderful, but we need to know when the cancer started, right? And you said it was quite a while ago.
Yes.
So she was less than 50 when it started.
Yes.
She would be someone that would qualify for the genetic testing. So thank you for your question.
Well, thank you.
Yeah.
Another call? Okay. All right, we'll take another quick break. Thank you, Jenny.
You're welcome.
Quay's still trying to learn.
I am. All right, good morning again. I'm Marquela Ellison, being a guest host today for Your Health and You. And right now we are chatting with Jenny Gertz about genetic counseling. So I think one of the big questions a lot of people have, and I'll word it a little differently, is like, what if I don't want y'all in my business? What if I do not want y'all in my business?
Yeah, so I think, usually when I'm exploring some reasons behind that, and sometimes it comes up in different ways. It comes up like that, or it comes up with, like, well, it's in God's hands. I don't want it's in God's hands. I don't want to. And, I think if you start exploring that a little bit more, I think sometimes what's underneath that is fear, and like, oh boy, if I just go about my life and I just keep doing what I'm doing, I'm feeling okay, so I don't need to pay attention to that, right? And I get it. Like, it's not fun to talk about people in your family that have died of cancer. That's not, but it's also there. And if we ignore it, it's not going away. And so for me, it's all about prevention. It's like wearing a seatbelt. You get in the car, you click your seatbelt, right? And hopefully you don't get in an accident, right? Hopefully you don't get cancer. But if you're not putting on that seatbelt, right? So if you're not exploring that family history, we don't know what we're doing. We're driving down the road without a seatbelt. So I would say, and especially for families where, and this happens generationally, where they say, well, that's private matter. That's private. You shouldn't be asking those questions, especially of your elders, And I think when they understand the reason why we're asking the question is so that we can prevent what's happened in previous generations from happening in the next generation. And it's all about knowledge being power. And what can we do to prevent cancer or find it early? So I think when family members understand that that is the goal, then they can come around and say, all right, okay, well, let me tell you what you need to know. And we don't need to know all the private business. We don't need to know where they were shining a light or who stuck a finger in what. Like, we don't need to know that.
Okay.
But yeah, because sometimes people want to go into a lot of detail, and we don't need that level of detail. We just need to know who had the cancer, what type it was, what age. That's all. That's all. So I appreciate that. And I think once people come to the door, then they're willing to have the conversation. So it sounds like somebody wants to have a conversation now, Jimmy.
Good morning.
Yes, thank you. Good morning. And forgive me for double scooping here, but the conversation has gotten real interesting and very deep for me. Tyrone W. speaking again. And good morning to all the individuals in the studio again. Dr. Izzard and everybody. Tyrone W. speaking. You spoke about the breast cancer, both in male and female. So let me give you two questions here real quick, and I'll hang up and listen. What danger is the baby in? Am I coming through?
Yep.
Am I coming through?
Yeah,
Okay.
you're good.
Yeah, you're coming through.
Okay. What danger is the baby in if the female has the breast cancer and she decides she wants to breastfeed over a period of time there? What danger is the baby in if she finds out that she's, can the baby still be saved if she's gotten some of that milk? And then you spoke about the males. If the male has breast cancer, how long does it take before that trickles down to the his reproduction there, and interferes with his sperm and all that? Then, so
yeah. So I think with cancers we're more concerned about because you got DNA, right? So every single cell of your body has the same DNA, and so when your cells replicate, when they reproduce, if there's a mistake, if there's a mutation in there, that mutation is going to pass on to all the cells that come out after that. So with something like we talk about cervical cancer, if you get a virus in your cervix, woman, and that those cervical cells are damaged by that DNA or by that virus's DNA that gets incorporated into yours, all the cells that happen after that can have the signal that tells the cells to stop dividing. That can be interrupted, and so that's how cancer starts, because the cells continue to divide, and so that's how cancer spreads. So what Tyrone W was talking about something spreading to the man's sperm, that's usually, and we're not concerned about that. We're concerned about the fact that is there something in that person's DNA that makes them they have a mutation that makes them more susceptible to developing a cancer. Okay, so we're not actually looking for cancer spreading to the sperm. It's actually your your DNA that sperm is making, does that thing have and actually what I'm concerned about the sperm itself, because half the sperm is going to go to what's going to be from the sperm will be a new baby's going to be half from the father, half from the mother. So, but we're looking at your genetic makeup, and is there something in your genome that makes you more susceptible to developing a cancer? You got things in your DNA. I mean, it's amazing. You make chemicals and things that actually prevent you from having cancers. So there's little edit things that are in your DNA that will automatically, if a cell is looking abnormal, will destroy that cell or stop that cell from developing. And some of those things we talk about antioxidants and things like that. Those are things, those radical changes that happen to the cell. Some of those things are things you can detect in someone's DNA. And so in fact, can you, Jenny, can you explain a little bit more about when they actually do the testing? What are they looking for? Are they looking for genes? Are they looking for cancer? What are they looking for?
Yeah, I appreciate you clarifying for the caller as well, because we don't pass cancer down through breast milk or anything like that, because exactly what we're talking about is when we we call sequencing the DNA. I'd say it's like reading a book, right? So we're reading that DNA. That's the DNA that you're born with. You get half from mom, half from dad, like you were saying. So we're reading the DNA just like you'd read a book, and we're looking for any mistakes or mutations in that DNA. And so we're not passing cancer down to our kids. We're passing down a DNA change that could possibly lead to cancer, not a guarantee. So it increases the risk. But if we know that ahead of time, then we can do something about it to intervene. So yes, it's DNA sequencing. So we're reading the DNA that you were born with.
Yeah. So we appreciate the calls. And the only way you learn is to ask.
Yeah,
that's right. There's the only dumb question is when you don't ask.
That's
right.
Yeah.
So
that's right. Yeah.
And I do have another question. It's a little off topic, but just appealing to those who may be listening. How can this assist somebody with like family planning? What are the benefits of trying to get the testing done if you're planning on a family history or trying to conceive? How could this testing be helpful and insightful?
Yeah. So as I mentioned in the beginning of the segment, there's a couple different types of genetic counseling we do. So there are many genetic counselors that work in the reproductive or perinatal area. And so sometimes people come and they see a genetic counselor before they get pregnant because they're concerned, maybe a family member's got sickle cell or they have something and they're concerned about their child having that. So we can do that testing before a baby is born or before the baby's conceived. Additionally, some people see us because they've had a lot of miscarriages and they can't figure out why they haven't been able to maintain a pregnancy. And so we're doing genetic testing to see if something could be going on that's causing the multiple miscarriages. So that's another area that we do.
Thank you. And then was there anything else you wanted to cover about just some of those common fears and misconceptions?
Yeah, I just wanted to make a comment about trust, because I think what Mr. Ellis has done here today has really demonstrated for me one huge way that we can build trust with our communities, and that's through storytelling.
Yes.
I think storytelling is so incredibly valuable because fears, we can start having things in our heads that may not be based in reality, and that can feed itself. And I think to combat those fears, hearing stories of success, of survivorship, of resilience, of changing your life around and saying, here's how I can use this information to be better, to do better, to live longer, to help provide my children a better life than maybe what my ancestors had. So I think your storytelling is really key. So thank you.
Well, thank you very much. And what I would say basically to the community, trust in yourself, trust in your family, trust in your physicians, and don't be afraid. Basically, if you have issues, how are you going to know if you don't get diagnosed? Hopefully, it's positive, it's not negative, but I want everybody to understand one of the things that you need to do, and one of the things that I try and do is spread the word and encourage individuals to go and get their screening, go and get their checkups done, and so forth. So it isn't just about my family. As a health griot, that's one of the things that we do is we go out in the community and tell our stories. We also basically try and make sure that they get the information about prostate cancer, about colon cancer, and other things. And if we don't know, we refer. You can refer to your physicians, talk to your family members, and so forth.
Yeah,
Yeah.
so community members showing up, it's huge. It's huge to build that trust. And I just wanted to mention one more thing, if you don't mind, because a lot of times people ask about cost, and that's important, right? Because they hear
Yes.
genetic testing, and right away they think, "Oh, that sounds expensive," right? And it is true. It used to be expensive. Back before 2013, there was one lab in the nation that could do the cancer genetic testing. They had the patent on the gene. If you believe it, the U.S. Patent Office granted a patent for our genetic material. So in 2013,
I shake my head.
in 2013, the Supreme Court said, you know what, actually, genetics happen naturally, and so you can't patent that anymore. So in 2013, now that it opened up the free marketplace, so multiple places could do the genetic testing. And nowadays the cost has gone down a lot. I compare it to, like, remember when getting a plasma TV, you know, you get how expensive those were. You get the big screen. It was like $4,000. But you're like, I gotta have that big screen. Now you go to Costco, it's like $500. You know, like what? How is that possible? Same thing. The technology has gotten so much better with our genetic sequencing, that technology, that nowadays, again, most insurances will cover it if you meet the criteria. But some people are like, well, I'm adopted, or I don't know my dad's side of the family. I don't know if I have a family history or not. So even if they don't meet the criteria for their insurance, we do have options for self-pay. We work with different laboratories. It might be at a maximum $250, which again, for some people living paycheck to paycheck, it's a lot, but it's come down a lot. And please do know that we work with you to make sure, you know, we get that insurance coverage when we can, ahead of time. So there's not going to be any surprises with the bills.
And going to the first caller. So when they do that genetic analysis, what else are they able to tell you based on that? Is it just cancers, or?
Yeah, it's just, so we do really focused testing. So what's called a cancer panel. So we're just looking at the genes for cancer, or someone we're seeing for infertility, for example, we're just looking at the genes for infertility, or the chromosomes for infertility. So we look at the family history and then use the family history to guide our genetic testing. But sometimes we see a family where they're like, well, on your mom's side, you got all this cancer, but on your dad's side, you got all this heart disease. So sometimes we do offer two different tests, but they're usually different tests. One to look at genes for the heart, another one to look at genes for cancer.
Okay.
I know the technology's changing though. So next year I might come back and I might have a whole new test.
Yeah.
And that made me think of one other myth that we commonly hear is about your dad's side of the family. People will say, well, you can't get breast cancer from your dad's side of the family. But that's not true, because the genes for cancer are the same in men and women. So on your dad's side of the family, maybe it showed up because dad had prostate cancer, but that's just how that, but then in a woman, that same gene might cause breast cancer or ovarian cancer, right? So you can inherit cancer equally from mom or dad's side. It's not like it's more likely to come from one side or the other. So I wanted to make sure.
No, thank you. Those are some really great points. And now I think we can transition into just talking about the community dialogue and just bridging that gap between community and research. So of course, a really nice panel of folks to help bridge that conversation. But just wondering, how do families begin to document their health history?
Yes. So I think, you know, any time to start is a good time to start. But particularly if you have like a family gathering, like around the holidays, you know, or in the summer, you have a family barbecue, and you see that auntie that knows everybody's business, or you see, you know, somebody. So what you're going to do is you want to take, you know, some paper or pen, a pencil, and start just asking about those stories, asking about who had what, and start writing it down, and just getting organized. So starting to organize that information. And I think, again, going back to the trust building and not trying to be in someone's business, explain to them why you're asking. You're not just asking to be nosy. You're asking because you want to do better for your health and your family members' health. We got a call.
Yeah, we have another phone call. Good morning.
Hey, good morning. How you doing?
Doing well.
Good. I just wanted to ask a quick question because obviously genetic information is really valuable for the patient, but also from a medicalization standpoint, I'm just curious, how's the data managed and handled once the information is collected from individuals? Thank you.
That is a wonderful
Mm.
question and gets at, of course, the trust issue. So
Right.
who's got
Mhm.
this information? Where is it going? Right.
Yeah, like 23andMe.
Yeah. Uh-huh. And who's going to sell it? Yeah.
Right.
Right. And that was the concern with 23andMe, which was one of those direct to consumer testing. You went on their website, you put in your credit card information, you spit in a tube, and you sent this company your DNA. And, there's some vulnerability there.
Mhm.
Right. So then when the company went bankrupt, they still have your data, and that is capital for them, right?
Mhm.
They can sell that. So that's another difference between the direct to consumer ancestry testing and the medical testing that we do. So the medical genetic testing is a part of your protected health record.
Mhm.
So that HIPAA protection is there. So just like any sort of imaging or other blood tests that you have, that is a private protected area that nobody can access without your permission. Okay. So the companies that do the genetic testing, they aren't often located in the hospital. So these companies are large corporations located in the United States, and there's about 3 or 4 of these large companies where they receive all of the testing for the nation. Okay. So they are required. There's multiple state and federal laws that require layers of privacy, so they de-identify. So instead of having your name to track everything, they have identifying
code,
numbers. Yeah, like a barcode. Everything's
Right.
barcoded, and so that's all private. And then when the results come back, they come back through a secure portal. And again, that goes into your medical record. And then we also provide you directly with a copy. And then if you want any of your family members to get a copy of that genetic test report or of your, what we call your pedigree, your family tree, I have to get a signed permission from you in order to share that with anybody else. And you have to tell me exactly who I can share it with. And it wouldn't be your whole record, but only the things that you want shared. So one of the things we encourage people to do is to share that pedigree, that family tree with their family members, and then the genetic test results. Again, they didn't need to know all your business. They don't need to know everything, but those
Right.
2 pieces of information are really valuable. So then they can take it to their doctor and say, hey, here my sister had this. This is my family tree. Here's the gene that they found. They said, I got to look into this. Right.
Yeah. Jenny, that's very helpful. And thank you, caller. I'm good with faces, but even better with names. So Aziz, good morning. That's who was calling in earlier. Dr. Izzard, because you practice family medicine, what are some things that people should bring to a doctor's appointment?
Oh, if you're one of these people who don't remember all this stuff, like, boy, like your past medical history, or I've had people come in and they tell me they had surgery and someone took their gallbladder out. They can't remember who did it. So if there's ever a complication, they don't know who did the surgery, or if it was a fellow, or if it was the if it was the attendant who did this procedure. But write stuff down, so you can keep it. You can laminate it. Your medications, that's another big thing. Bring your medications, put it in a bag, and bring them all in with you, because a lot of times people can't pronounce the names of what they're taking. They don't know what dose it is. Bring your medications with you. And particularly, if you're older and you have problems with memory, you can bring a family member in with you, and someone who might know the history better, especially if you're coming in for a specific issue. Because a lot of times we don't have the language to describe what's going on. So someone comes in and says, their arm hurts. Well, what does that mean? Hurts. Hurts can mean like someone punched you in the arm. Hurts can be an aching. Hurt can be burning. Hurt can be numbness and tingling. All those are hurt. So you gotta, if I challenge you to try to figure out better ways to describe, what pain is or what your symptoms are. But the main thing is, definitely, especially for a first visit, you want to bring in your your medications, allergies. You want to bring in your family history. You want to bring in your past medical history, including things like when your surgery was, because a lot of times it makes a difference if you're, if you had that carpal tunnel surgery last year, or if it was 10 years ago. It might make a difference. And it helps if you know where it was done too, but really just if you just have the history of when things were done and what year approximately, and then hospitalizations. When were you hospitalized, and not just recently, but going back to even if you were a child and you were hospitalized. Let's say you're hospitalized for asthma, when you were a child, and you haven't been hospitalized since then. That tells a whole lot about about how bad your asthma is. So. Those are the main things: your family history, your past medical history, your medications, and your medication allergies.
Thank you. Um, I know I take my grandparents to their doctor's appointments. So just wanted to circle back on that. Not everybody needs that additional assistance, but just making sure they're advocating for themselves and that they haven't forgotten anything. So I just kind of sit in the room and be quiet, but I try to chime in if anything is missed. Make sure they bring their medicine, but it's all very helpful. So
yeah, and a lot of times you find out more from the other person that's there than you do from the patient.
Yeah.
No, they'll tell you something. He says, no, that wasn't quite it. Make sure you tell them about such and such. Tell me you passed out last week. You didn't. Especially with guys, we don't tell everything.
Yeah, we don't
the
tell
wife
everything.
will tell. Yeah,
No, we don't tell everything.
yeah, no, definitely. How do we talk about genetics without creating fear? How do we dumb it down or encourage people to check it out? Especially if we have a conversation, that is talking about some of the things that could be potentially hereditary, things of that sort. And so I guess I'll ask both of you, Dr. Izzard or Jenny, however you guys want to answer it.
I would say particularly if you have a new diagnosis, you should let people know. So if you found out now you're diabetic, you found out that you had a cancer, like Mr. Ellis. If you found out that something new was going on with your health, you should share it with especially with your siblings. So when you're together for I know this will have your holiday parties now kind of digress into talking about your health,
Right.
but you get to a certain age and that's what happens anyway. So, tell me about that knee, Johnny. How you doing? Oh man, they told me I got prostate cancer now.
And
So,
that's how you find out information.
It is. And also, part of the value of those conversations is that you can encourage other people to, like my brother, I've been trying, you got to go and get your colonoscopy, and so, so those are times also to encourage other people to, make sure that your loved ones follow through with getting their screening done too.
Yeah.
Right. And if you would mention that they put you to sleep when they do that colonoscopy too. It's not there again. You're not awake. So when you wake up, they tell you the results.
Right. And it makes a difference when you hear from real people how the experience was for them. Now, it's not going to be the same for everybody. Some people might tell you, oh, that was the worst tasting stuff I ever had. But you talk to enough people, you can say, it wasn't that bad. And so it kind of allays some of the fears you might have just because you're unfamiliar with the screening test.
And it's better than getting colon cancer.
It is.
Yeah.
It is.
Yes, it is.
All right, we're going to take another quick break and we'll be back. Thank you.
Good.
All right. Good morning. Again, we are here with Your Health and You and Your Health, and wrapping up with Jenny Gertz and just talking about community and bridging that gap with community and research. So, just one last question, and it's for everyone. What role does community education play in rebuilding trust?
All right. So I have to say that, all communities deserve equal access to early detection and disease prevention. And historically, certain communities have been excluded from access to genetic counseling and testing. So we're trying to overcome that. And I think the more success stories we have here, like Mr. Ellis here talking about what he's done, the more community members that are willing to put their story out there, increase awareness, and help people think about what could this mean for them and their family. I think that's really the key to moving this forward. So
Yeah, I think the big challenge with medicine has always been the numerator versus denominator. And what does that mean? So the numerator, when you have a fraction, the numerator is a top number. So that's you, that's an individual, and denominator is when you're looking at the population. And so a lot of these things, the only way we can give you accurate information or accurate recommendations or make accurate guidelines is if we got enough people in the denominator. So when we're talking about things like All of Us that we've been focusing on earlier, and or a lot of the genetic testing, it's not for us, it's for the other people that come around after us. And so we need people to and for historical reasons, legitimate historical reasons, I know people are afraid to be involved with research because more times than often we have been the victims of research rather than the beneficiaries of it. And so people think about Tuskegee, and they think about Henrietta Lacks and things like that. But and I've said this before, and if you're not at the table, you're on the menu. Until we get to the point where we're at the table having these discussions, we're going to be on the menu, and they will find ways to get our DNA. Right. But if you can be at the table where they're developing these laws and rules about ethical behavior, about how you use the DNA, we can make sure that it's used in an ethical manner. So I said, as Black folks, we need to get over the fear of and I say that in quotations, can I get over the fear of being part of research, because it's needed. It really is needed.
And so many of us are at the table now. Mr. Ellis, as you were saying, your daughter, is in radiology, and I know that gave you some comfort, having more people in the medical field, seeing more people like you, having those conversations helps. But what do you think about just that bridging of research and community?
Well, I think bridging it is very, very important. That's one of the reasons why I'm a health griot, because the simple reason is I want to help my people. I want to help people. I want to reach out to the community. I want to let them know that there are resources. And like Dr. Israel said, is we as individuals, especially Black people, first thing that we say, we don't want to be a guinea pig. So that's why we are not part of half of the studies that's going out. And I give you an example. Why do you think that high blood pressure, a lot of times, why do you think they have to give people so many different type of medications? Because the study wasn't done on us.
Right.
So then they have to decide, okay, what is it that's going to help this person and help them being able to get a medication that's going to stabilize their blood pressure and so forth. So as a health griot, there again, I want to continue to help people, not just my family, but I want to reach out to the community and say, I want everybody to be involved.
All right. Thank you so much. And now we're going to move to our next segment. We have Dr. Rick Kittles joining us virtually. Good morning.
Good morning.
How are you?
I'm great.
All right, Dr. Kittles. I'm looking forward to hearing you, man, and to seeing you. Well, we'll get to that.
Yeah, definitely.
Yeah, definitely.
Yeah, we'll have Dr. Kittles will be joining us in person next week, and we'll talk more about that later. But yeah, Dr. Kittles, do you mind just introducing yourself, telling us more about you?
So I was sitting and listening to the conversation earlier, and it's right up my alley. I'm a geneticist by training, a genetic epidemiologist. So I actually look at genetic factors, risk factors for disease. And the disease that I've been exploring for most of my career has been prostate cancer. And so, and other health disparities besides prostate cancer, but mainly focused on prostate cancer and why we have this disproportionate impact in terms of incidence and mortality between Black men and white men and Asian and Hispanic men. So that's the bulk of my work. But I've also been actively involved in this space around genetic ancestry. And my team has really explored leveraging how do we look at particular genetic markers or variants in the genome, these changes that as was being discussed earlier, how they are sort of inherited and how they provide a record of the history of that individual, that family, that community, that region, that space on this planet. And so, a lot of genetic anthropologists really get excited when you look at a data set and you try to uncover some of those family links, ancestral links, and then also the migration of humans across the world. So a lot of that also is tied to disease because, you think about it, diseases, in particular, a lot of the cancers and complex diseases are genetically determined. And so you have this genetic history in a population that overlays the disease history in the population. And so when you can really look at sort of behavior, genetics, biology, and disease, and really tease apart sort of what's contributing in that community. So I'm, as I said before, I'm a geneticist, and I'm also a research leader at Morehouse School of Medicine. I'm a senior vice president for research. Very exciting role. The institution's only 50 years old compared to some of these other academic institutions. But we've had a big impact in those 50 years. So very, very excited about being here and coming out to Milwaukee next week.
Yeah. So let me ask you a question. So can you do, first of all, in the medical community, there's a big discussion now about what is race.
Mm-hmm.
And should we even be talking about race? Because, and maybe you can elaborate on, the difference between genetically between different races.
Mm-hmm. Mm-hmm. So this is not a new debate. I mean, this debate has been going on for, since anthropologists really started looking at the different so-called varieties of man, across the world. And so, early anthropologists, early historians have always tried to categorize humans into these racial types. But one of the things that we know, and for the most part, most scientists believe and agree on, that there are no human races. We use races as a subspecies category. So you have races of a particular species of fish or some snail or something that's diverged over time. Human variation and the human existence hasn't occurred long enough for there to be these breeds or these subspecies that we want to call races. And so there's a lot of genetic variation out there, but a lot of that is structured around the migration history of modern humans. So I don't believe in race biologically, but I do believe in the social cultural construct of race, especially here in the United States, given the history of Blacks in America, right? So you cannot say that there are no races and walk away thinking that folks are going to agree with you on that. These so-called racial groups are social cultural sort of entities that were established based on the history of the country.
Mm-hmm.
No strict biology behind it, but more so a proxy for some shared culture, shared environment. And so when I say African Americans, or Hispanics or Native Americans or European Americans, what I'm saying is that those are groups, those are social cultural groups, not biological distinct entities, but social cultural groups that allow me to measure and monitor and do some surveillance, to see, for instance, if there's any inequalities as it relates to health or quality of life or whatever. So the racial groups do provide insight, but not biologically. Does that make sense?
Yeah. So given that information, do you think as we develop new medications and new treatment guidelines, do you think that race should be considered a criteria for, like, for instance, how we treat men with prostate cancer? Should we be more aggressive with Black men just based on on race, or should we be looking at other markers?
So at where we are right now, I believe that yes, we can stratify risk based on self-reported race, and I say that I say that loosely. It's not one of those situations that I think is going to last forever, because what we're doing now is we're doing a lot more sequencing of the genomes of individuals, and ultimately, and I say within the next 10 years. Most people will have their DNA sequenced, and that will be in their medical history. Okay, I firmly believe that's where we'll be within 10 years, and then that information is the ultimate sort of Bible, or the ultimate sort of in terms of what you biologically, where you get your ancestries from, and what your risk factors are, and all of that, irrespective of race. Okay. But at the same time, when we say I'm African American, that does provide some meaning, and that you might be able to leverage in the clinic. Okay. It might be a dietary influence, or it might be a cultural influence that you can further dig deeper with the patient on.
Mm-hmm.
So for instance, we know that everybody likes fried food and burnt red steak. Not everybody, but there are communities that really enjoy that, right? And so if you capture that information in the dialogue with the patient, you can then dig deeper and say, look, you shouldn't be eating burnt red meat, because it adds these FIPS, and they are carcinogens, or cancer causing. And they accumulate, let's say, in your gut, and you can, end up with colorectal or even prostate cancer because of that. So you can have those discussions based on the individual's cultural sort of dietary lifestyles. You see what I'm saying?
Mm-hmm.
And so let's not say that race should be ignored. It just should be leveraged in the right way.
Mm-hmm. I'm kind of curious about, so how did you get to what you're doing? I mean, this is, because I'm always curious about how people choose their their careers, especially when you're specializing in something. How did you decide you want to specialize in genetics?
I happened into it, I guess, because I really didn't like genetics. The first genetics course I took, I felt that the professor was kind of racist, the way that his examples that he would use, but that was early genetics. I mean, the early genetics was rarely it was developed by these folks that we call essentialists, who believe that that genetics overrid everything, and breeding, there's particular important lineages and others that weren't. So anyway, I never really got excited about it. But what excited me was to try to understand why people looked different when I looked around the classroom, and why did some people get sick and others didn't, and why, when some people got sick, it really developed quickly. So I was really interested in those variations in terms of phenotype, physical traits, but then also disease risk and outcomes. And so I knew genetics had to play a role in that. So I started studying more and more. And next thing you know, I'm in a genetics program. but
in a genetics program, you're running the program.
And Dr. Kittles, how does ancestry research improve prevention and screening?
So I'm going to talk a little bit about this next week. One of the biggest debates in urology, these are doctors who particularly study and treat for, individuals with prostate cancer. One of the big debates in that area is how useful and how predictable is the PSA test, which is the prostate specific antigen, the blood test for detecting if you have elevated PSA. Then you have a biopsy, and then from the biopsy, they will tell if you have prostate cancer. But before the biopsy, you would have a PSA and a DRE, a digital rectal exam. I think you guys talked about that earlier. So in that group, there are some urologists and other physicians who believe that PSA is not a useful biomarker for determining cancer, and actually it's one of the best that we have right now. It's been one of the best. It's not the best, but it is one of the best biomarkers. But when we look at the predictability of PSA in white men, it does appear to be different than the predictability for prostate cancer in black men. There have been studies on that, and I've published some myself, and other groups have too. And so why is that? Why is the PSA, the protein, that test, different between white and black men? And it's not 100%, okay? There is variation even within whites in terms of prediction for prostate cancer with PSA. A lot of that has to do with genetics and the PSA gene and genetic variants in there. These are those mutations that are in the gene that you inherit and pass on. And some of those are structured geographically, like in West Africa, some of those genetic variants in the PSA gene that cause the PSA test. Because of those variants, the PSA test is a lot more predictable for black men than white men. And so I guess maybe about 10 years ago or even more, there was a big debate among epidemiologists in terms of how useful is the PSA test. Should we recommend it or not? And they gave it a low recommendation. This is about 15 years ago. And a lot of folk were upset, in particular African-American urologists who were treating African-American patients, and folks like me who were out there screening. We were screening in Chicago, thousands of black men who've never had a PSA, over 65, never had a PSA. And then all of a sudden you get a recommendation saying that the PSA test is not good, and they stop. And it changed the landscape across the country in terms of urology, because folks stopped studying prostate and went to other surgical sort of areas like, I don't know, pelvic reconstruction or something. and so there wasn't a lot of attention on prostate cancer because of the recommendation. And so now we see this elevation in terms of men coming into the clinic who are presenting with late in the game with late stage cancer because they were not screened. They weren't picked up earlier like we were at one point. We were on that road, in terms of improving screening for prostate cancer. So now it's almost like we got to start over. But anyway, back to the story about ancestry. When we look at the differences in predictability between black men and white men with the PSA test, and we stratify the African Americans based on low, medium, and high West African ancestry, we see that with increasing African ancestry, the prediction for PSA improves. It increases, not improves, but increases. Mm-hmm. So genetics is playing a role here in the usefulness of that test. Okay. And it's not because of some self-report or, being black, having black skin. It's more so, where your ancestral background came from.
Mm-hmm. Hey, let me ask this question. So, most of us here in the U.S. Have, at least African Americans, have West African ancestry. Mm-hmm. Does that change when you look at people who have East African?
Yes, and North African, even South African. And so when we structured our database looking at ancestry for African Americans, we in particular started to focus on West and Central Africa, because that's where the bulk of the enslaved Africans came from, that were brought here during the transatlantic slave trade. And so the 95% of enslaved Africans came from West and Central Africa. We look at the genetics of East Africans and compare them with West Africans. We do see some big differences there because those populations have been isolated, and there wasn't a lot of migration and gene flow between the East and the West coast of Africa. There was some, but not a lot. And the same thing with South and North Africa. So those areas, when we look at the genetics of those populations, they're structured, what we call structured geographically, meaning the closer those individuals are in terms of where they live, the closer their genetics is. So if you look at two individuals in West Africa, genetically they'll be more distinct the further they live apart. They are apart.
Mhm.
You know, because people mate within certain geographic regions,
Right.
and so you share genes within these clusters. And so we structured our database so that we knew geographically where these samples came from, and then also their relationship to other groups who were close and far away in that region.
It's all very interesting to me. Yeah.
Yes, it is.
Yeah.
Very interesting.
And I don't know, because I kind of geek out, just being a doctor. I kind of geek out in the science here. But
Yeah. And we get to chat more about it next week, which I'm very excited about because it's been a really great discussion. So again, we have our event from our roots to our health, genetic ancestry, and health disparities. And our main speaker will be Dr. Kittles. That's next Friday. My apologies, next Saturday, February 28th from 1 to 3:30 p.m. And you have a chance to grab a bite and connect with him a bit more. That morning will be at Summer of 85. If you want to connect with him and ask a few more questions before the event. We'll also have Dr. Izzard and Erica Sinclair with Health Connection, a part of that discussion. So what should people expect at that event? What should they look forward to learning more about, Dr.
Well, first of all, it's going to be a real laid back sort of, discussion. It's not going to be, one of those academic, well, I'm up there at the board and pontificating and all that. It'll be a laid back discussion. It'll be almost like going to the barbecue or to the barbershop, and we'll talk in lay terms about these issues. I've had a lot of time invested in exploring this issue of race and genetics and health, and then ancestry also in health, and intertwining all of that together as we try to come up with these predictive models for risk for these diseases. It's not all genetic, and it's not all the environment. Right. And I think that the sooner or the quicker we understand that, the more the more we'll understand sort of how to fix it. There'll be a lot of discussion about non-genetic, sort of the behavioral lifestyle risk factors. There'll be some discussions on family history and why it's so important. I got some stories about why it's so important to understand your family history, even if it's given a difficult topic like cancer. We have to be able to understand sort of what our family history is, and then how do we leverage that to improve the health of not only ourselves but the next generation behind us.
And do you feel like this event coming up, this is something everybody should attend? Right?
Yep. Young and old. I want families to go back home and be able, the young folks ask questions with their parents or aunts and uncles or grandparents, and be able to, have some nice dialogue for future sort of actions. And one of the things, I'm as I said before, I'm at Morehouse School of Medicine, where I have a bunch of students that are.
What happened?
Uh-oh.
We lost.
I think you got cut off accidentally. Yeah. So I want to just mention again, Dr. Kittles will be joining us next Saturday for From Our Roots to Our Health.
Mm-hmm.
Oh, we're back. All right.
I came back. No, I was just saying that I really get excited when the young folk understand and get excited about this work and move in that direction in terms of scholarship and the academy. So
I hear you, because they're the next generation. They'll be taking care of us.
Right.
Yeah.
And so we gotta pass this on to the next generation.
Yep.
I just wanted to add, I appreciate how you said this event's for everybody, because I always say every family history's got something in it.
Mm-hmm.
It doesn't matter if you know what it is, so you know what you can do about it.
Right.
So, none of us escape this world without something happening, right? So if we can anticipate what that is, that's the key to prevention and early detection. So that's why it's for everybody.
Right.
Yeah.
It is.
Definitely. I think we just have a couple minutes left, but any final words you want to share with us, Dr. Kittles, or with the audience?
I'm just excited about the coming out there next week. Family history is important. Ancestry is important, and we'll have some nice dialogue around those around that next week. I was just thinking about what was just said. When you go to the doctor and you say, I think I might have high blood pressure or sugar, diabetes, as they say, one of the first things the physician says to you is, "Do you have a family history?"
Mm-hmm.
You know, and this is where it all connects. And you know, we want to be in control of our health and our future, and being able to answer that question is important. So and so that's sort of what we'll be talking about next week. So
Yeah. So will you be talking about other kinds of health issues, health disparities, or is it just prostate cancer?
no, be more than just prostate cancer. It'll be it won't be a complete list of the disparities, but the ones that I've been involved in
Okay,
research.
you heard that, folks. You know,
Yeah.
so it's not just for our men. You know, it's for everybody.
Right.
Yeah, we'll all take something away from it. Thank you again. Any final words from our guests today?
Thanks for having me. This has been
No,
a pleasure.
Jenny, it was great having you.
Yeah.
And of
Yeah.
course, Mr. Ellis
Yeah.
again. Always good to see him.
Yes, thank you
Yeah.
very much.
And Quay, I think Deb better be nervous about her job.
Right. This was fun. Definitely thankful for the opportunity to host this. Thank you for everybody who tuned in today. And again, please save the date. We hope to have you in attendance. If you look up Prostate Health Equity Project on Facebook and Instagram, you can learn more about the event. Again, that's Saturday, February 28th at 1 p.m. at America's Black Holocaust Museum.
And it's free.
And it's free. Thank you. Yes. Thank you, everyone. Enjoy your Friday.
All right, thank you.